Welcome to Home Health 360, a podcast presented by AlayaCare. I'm your host, Jeff Howell, and this is the show about learning from the best in home health care from around the globe.
Hi, folks, and welcome to the Home Health 360 podcast, where we speak with leaders in home health and home care from across the globe. I'm your guest host, Erin Valier, Regional Director of Sales for AlayaCare Software. And today I'm joined by two special guests, John Kunysz and Andrew French, to talk about investing in systems to personalize the patient, family, and employee experience. Let me introduce our guests. So, John Kunysz joined Intrepid USA Healthcare Services in April of 2018 as the company's president and chief executive officer. As CEO, he is responsible for leading the organization's ongoing growth initiatives with an emphasis on delivering personalized, patient, and family-centered care. Under John's leadership, Intrepid was named the 12th largest provider in home health care services in the country. That's impressive. He is a visionary executive with more than 30 years of diverse experience in the healthcare space, including electronic health records, as well as patient experience leadership in acute care, physician group practice, and home healthcare environments. John received his Bachelor of Science in Business Administration, Accounting, and Marketing from San Diego State University, and his Master's of Business Administration from the University of California at Los Angeles. Additionally, he is a certified public accountant and board certified fellow in the American College of Healthcare Executives. Wow, John, welcome to the show.
Thank you. It's an honor to be here, Erin, and join you and Andrew.
Oh, we're super glad to have you. And I have Andrew French with me. As president of Get It Analytics, Andrew has a passion for big data and bringing innovative technologies to organizations of all sizes. When leading the development of new software tools or consulting engagements, he utilizes his experience gained over the last 17 years in the healthcare sector. Andrew has worked closely with clients to support software product selection, implementation, and ongoing optimization. Within the home healthcare space, Andrew continues to work with large agencies supporting their growth and operations, and he supports them in navigating the ever-changing regulatory environment. In his free time, if that's a thing, Andrew enjoys flying advanced aircrafts, hiking out west, spending time on Lake Michigan, and learning about new technologies to improve healthcare for the underserved populations. Andrew received a Bachelor's of Science in Information Systems and a Master's of Public Policy and Public Administration from Northwestern University, as well as a Project Management Professional Certification from the Project Management Institute. He also holds an airline transport pilot license issued by the FAA. Where are we flying, Andrew? Welcome to the show.
Thank you. Happy to be here.
We're glad to have you as well. Now, before we dive right in, you both have extremely diverse backgrounds, as we just learned. Would you mind sharing with our listeners how you first became passionate about the healthcare industry?
Sure.
John?
Who do you want to go first? Erin, you want to go first?
You can take it, John.
Thanks, Andrew. It's interesting. The diversion also has a conversion, which I'll talk about in a minute, because my background, I was at the Price Waterhouse side of PwC early on in my career, and then left and was doing a management consulting firm, kind of a boutique mini McKinsey, Booz Allen type firm with owner-managed companies, PE-backed, venture capital-backed in Southern California, and was always on this consulting side of the world and working with boards of directors and CEOs. And one of them said, I've got this $70 million dental HMO that's almost like a startup, and they are in desperate need of like a COO to join them. And I know you want to kind of move into that track. So I ended up joining the 750,000 member, 14 state dental HMO out in Southern California. But my background had always been sort of project management, change management, auditing, consulting services. And I'd also had sort of a manufacturing background growing up as a kid. My dad was in charge of process development for Sunkist. So I always viewed process manufacturing things as how it was. And when I got into healthcare, I looked at it as a manufacturing process, and we made our own rework more than any other industry I've ever seen. And so the DNA I share with you, Andrew, was that project management experience. And that's how I viewed everything that I had to do in healthcare, breaking it down. And because it's daunting if you try to look at it in the totality of the clinical experience, and being a non-clinical person in clinical environments was something, Aaron, that I loved what clinical people did. And it was truly the art of medicine, which is still there, and that heart connection and ability to look at a patient and sense something's wrong is so special when I watch our clinicians. And what happens is it's the back office processes, the technology things that get in the way of that moment of care, which is what I love to focus on. And that's what got me passionate about healthcare to begin with. And frankly, from that point on, in about 1988, I stayed focused in on healthcare exclusively.
Yeah, I can imagine your background in those processes became really handy, because I know process is something that I focused on in my career before Allied Care, and it was all broken. It was just all broken. Andrew, what about you?
Almost a similar story, just probably jumped into the industry a little bit later. So my first job in 2004 was actually for Mercer Human Resource Consulting. We were a third-party administrator for benefit plans in Iowa. And so, I came into this very young thinking, oh my gosh, this healthcare industry, this is such a polished, well-working machine. Within 2 weeks, I was like, oh my gosh, this is not what I thought this was going to be at all. It was mainframe systems and manual processes and carbon copies and mailing things. So I really kind of kicked off from there and was like, what can I do to make these processes better for, just our day-to-day operations? And from kind of a project management perspective, it's like, why are we doing things, this way? Well, that's the way we've always done it. We set this mainframe up in 1950, and, we've always had these people that did these things. So I actually kind of got my claim to fame building automations that sat on top of mainframes to start with. And so I built Visual Basic code that would emulate a user on the system. And it's like, well, now, this used to take us 10 minutes to enter this form. We actually pull this from a spreadsheet file now, and it takes 3 seconds for our program to run through it. So really jumped in from there, and it was like people were open to that change. It's like they just didn't have anyone with kind of the hat on to come in and say, hey, this is a way we can do it. Do we agree? Let's test it and let's get it done. I jumped from there over to Blue Cross pretty quickly and started doing very similar things for Blue Cross Blue Shield of Illinois. They also were on mainframes, still are today in some capacities, but just tons and tons of opportunity for automation. So from there, I'm like, okay, well, now I've been on the data side for a while, but I hadn't really gotten into the patient care experience. And so I actually jumped over to the provider side and started to get very specialized at that point in behavioral health and substance abuse. So I helped lead a community mental health center in the Chicagoland area. And it was interesting there too, because while they were a bit more established and had a lot of good processes in place, it's like, let's really look at the quality that we're providing for patients and figure things, just little things that we can change and make projects out of it. We ended up becoming a center of excellence for the Joint Commission for how we were working through transitions from patients that were in the inpatient unit moving to outpatient, which is a very important part of their step down. We would lose them. We would have our community mental health center as part of their discharge plan, and they'd never show up the next day. So we actually built some special programs to move those patients from inpatient over to outpatient. So it was a warm handoff. It seems like such a minor thing, but for a behavioral health patient, that's so huge for their continuity of care. So from there, I sort of just kind of jumped into the consulting side. So I've had a lot of these projects I had led and helping select electronic medical records, moving through those projects. So kind of a robust background. I've hopped all over the place, and, pretty much any well in healthcare, I've got some depth of data there and knowledge that I've worked on to date.
That's impressive. And I love the subtle similarities in your backgrounds. I'm really excited about how the conversation is going to go today. And I know you both really want to talk about investing in systems to personalize the patient and family and employee experience. Well, that's a really broad topic. Can you each define for the listener what it means to you to personalize this experience for these cohorts? Like from an end user standpoint, how am I going to feel when I'm receiving these things? What's it going to look like?
Yeah,
Andrew? or John?
No, Andrew, go ahead.
No, John, I'll let you kick this one off. I think this was up your question umbrella.
So as you were talking in your intro, I kept remembering that same shock and awe of the amount of redundancy and rework that we do, and why do we do these processes, and the extra 30 to 40% of costs that occur in healthcare is for non-essential back office double checking, triple checking that really added no true value to the patient care experience. And so particularly as I got into the post-acute arena 4 years ago, what I realized there was, I said, it was like going back 25 years. Because most of my career had been in the acute care large physician practice environment where we had invested. We moved away from green screens eventually, right?
Yep.
I was a former DBase 2, RBase coder, DBase 3 person. So I knew enough about IT to be dangerous, but I freely admitted it that I didn't want to get there. But what really struck me was how the internet started to impact our perception of things. And it wasn't about necessarily access or kind of the paradox of choice that sometimes overwhelms people when you log on to something and Google something for a search, but really trying to reduce the friction that's involved in transacting and also creating a more personalized care experience, because that's something that I've been almost messianic about for the last 4 years. Of home healthcare is still very archaic. You still have people picking up a phone, trying to schedule things with a patient, or, we're acting like the cable company. We'll be there sometime between 8 a.m. and noon or 1 and 5. And that's not okay for patients. That they're used to being able to say, here's my preferences. I'm available at these time slots. I'd like to do this. Why are we sending caregivers out? And I call them care team members versus employees, Aaron. It's just, I do a lot of these weird words in our company, right? That people subtly begin to learn over 2 years it matters. But why are we sending people that are deathly afraid of dogs into homes with dogs, or that are allergic to cats into homes with cats? And we've had physician preference cards around for 30 years in acute care environments. There needs to be preference cards for both patients and care team members, so we can line them up, and the scheduling systems allow us to sort of align this. And it creates not just a better sort of interest experience, but it can be things that may be sort of backgrounds and interests. I've talked before about if you had somebody that was into musical theater, what a great opportunity if they could take care of Julie Andrews or Robert Goulet. That's kind of interesting. Now I'm enriching my experience for both my care team member that's going beyond the compensation level of the job, because we got 60% of the workforce is no longer saying that taking care of people is going to keep me into nursing because it's something that I value. We've got to come up with better things that align to them personally. That's
fascinating. So what I'm hearing you say, like from an end user standpoint, to you, I'm going to have more enjoyment because I'm going to get to work the shift that I want with the person that is fascinating to me. And from the care receiver standpoint, my outcomes might be better. I might have a better experience and, get all my needs met if this technology is being employed. Is that kind of where I'm hearing from you?
And actually this started something years ago. I started virtualizing the back offices of healthcare. I did this in the acute care environments. I did it in physician practices. We were doing that at Intrepid when I started. So I remember in March of 2020 when I called our folks and my kids had said, hey, they were at Salesforce and at Amazon and said, Daddy, they're sending us home. I called our IT and said, buy everything you have to send everybody home this weekend. They go, what? I go, it's going to be sold out. Send everybody home. They're like, what? And I go, just do it. So they did it. We were the first home care company to have everybody virtually at home. And our revenue cycle lead, she came back to me a few months ago. We were looking at, should we bring back to work or not? She goes, never again. You are right. I have people in Coeur d'Alene, Idaho that are 3 times more productive than the people I had at our National Support Center. I love it. She goes, the virtual world is awesome. So that's, Aaron, kind of the side where I see this is we're getting ready to launch in January your patients, your schedule. type program for our clinicians to say, look, if you want to work a weird schedule that's split, maybe early morning, later in the evening, that's great. Our patients want it as well. Some patients have sundowner syndrome. They're up at 5 a.m. To them, 6 o'clock is our 8 o'clock. Why are we doing visits at 9:30 until 4 o'clock Monday through Friday? You have to create something that's maximum flexibility for both the patient, for that personalized experience, as well as the care provider. Otherwise, we can't tap into workforces that aren't going to go to a traditional schedule anymore.
Yep, that's an excellent point. Keeping everybody happy.
Yeah.
Andrew, what's your take on it?
My point on that too is retention. And so, I mean, as much as it is for, the care for the family, if you can get a caregiver that's in the home on a schedule that they want and they're consistently with that patient, you're not staffing a bunch of other people in there because they've got an odd schedule, the quality of care just goes up intrinsically for that. They know the patient, they know the home, they have the relationship built with them. And we're in a market now too for nurses where anyone can pick up the phone and be at another home health agency tomorrow. And so it's like if someone else starts offering a sweeter pot or that schedule that they're looking for, they're going to jump ship and they're going to go somewhere else to go and do that. So, I mean, as much as it is about the patient experience, it's also about the caregiver experience and making sure that you can retain nurses within your agency. If you're still on paper and, paper schedule requests and everything else, you've probably got 1 to 2 years before all those nurses are going to hop to another agency or someone's going to come and snatch your agency up and buy it because the technology just isn't there to support what people want in the homes now. Yep.
You bring up an excellent point. I think I read somewhere, because we have access to all of our tenant data. We looked at it in some interesting ways, and we found that, when there's more than one or a cycle of caregivers in and out of the home to provide care, the overall outcome scores goes down. Like, people like consistency.
Yep.
So you guys do bring up an excellent point there.
Yep.
And that just highlights to me the shift towards the consumer-driven market. And it's just in the last decade or so that the healthcare industry became a little bit more focused on the opinion of the consumer about the services that we deliver. While other industries like banking and retail, those industries have always been focused on what the consumer wants. Now let's look at Australia in the healthcare, right? They're largely consumer driven right now. So this is an example. The individual has a really strong voice and influence over all the care that they receive in the home. Now, more globally, if you want to layer on top of the shift to being more consumer driven, COVID, over the last year or so, we know that COVID has really catalyzed this push to make home the center of care for patients, especially the chronically ill and the elderly. Now, I know both of you are really passionate about personalized care. Can you share why you feel so strongly about this push to personalize the care at home experience for patient families and employees? And Andrew, I'd like to give the floor to you.
Sure thing. I mean, it's where we're going. We have the technology out there to support these things now. And, people have their iPhones, they've got apps that do all of these things. And we're still probably a decade behind in the healthcare space with delivering that technology. Like, hey, when is my nurse coming? Or I want to make a schedule change for that. How do we do that? We still pretty much pick up the phone, call the office. They have to go into the EMR scheduling system and work through that stuff. But for anything else, ZocDoc, scheduling appointments, large health systems, you've got all of this stuff on your phone. And so that's really, step one. And the generations don't really like talking on the phone as they, move forward with stuff. Like, we're missing a market where it's like, we've got people that are retired now that have home health care, but where you have this technology driven group that is going to be moving into the home care space at some point in the next 20, 30, 40 years. And in some cases already are. There's older people that are just comfortable with technology and prefer that modality for working for things. So the sooner we can get there in our technology solutions to bring those things they see in other verticals of the industries out there to them and get it in their hand, get it in an app, I think we're going to have better outcomes there. The other thing too, for agencies that are still on paper and doing things, I mean, just for continuity of care, if you have a disaster in Florida and there's a hurricane and you need to jump somewhere, you forgot to grab your plan of care. You don't know what your last medication list was where you had 5 things that changed. Why is that not in a portal or on a phone across the board for everyone? Those are just such simple little things, and the technology's out there to do it. And those are things that they're going to drive in the home. Like, those are things that's my personal care. Like, I need access to it wherever I'm at.
Definitely. At least in the US, I know that we have that more on-demand feel right now. We want to order it and have it there. Yep. John, what does this mean to you?
It's interesting, Andrew. One of the things you reminded me about in your comments was the fact that I look at how we view our consumer experiences now, and yet in healthcare, it's been really archaic. And what struck me, and this is something that when I got into post-acute, it's one of the most complicated care environments because you're completely virtual. We've got a 7,000 bed hospital across 17 states with 2,000 caregivers, right? That's a complicated clinical setting, and you don't have control over that clinical setting a lot in the home. But also the labeled patient that we typically have and we're used to in an acute care environment is not what we really have to pay attention to in a aging in place senior care environment, because they may not tell us the truth. Oh, I walk fine. I never fall. I don't need a walker. I take all my meds.
Oh, yeah.
I just have a little bit of a nip now and then, maybe a beer or two in the afternoon, right? What's interesting is the multimodality with which we have to incorporate patient input from not just the patient, but spouses, brothers, sisters, children. You have to do this. And we don't do that well because we don't have the communication. I call it this patient-family communication stuff. And Aaron, we've talked about this several times at conferences. I'm huge about that because we know more about our Chewy dog food order that we just got or something from Amazon or your prescriptions from CVS and Walgreens than we do about any kind of our home care visits. And you should be able to check in and find out what was the status with a 2-factor authentication so it's secure and be able to ring in. So we've been looking at a lot of those technologies that help enable that. And part of, Aaron, what drove, I've been talking about the family-centered medical home for at least 15 years. And it came back from when I went to an ACHE Congress many years ago. It was one of the commanders dressed in his dress whites in the Navy that set up the first family medical home for the U.S. Navy. And it was a multimodality, kind of multifactorial way in which they treated patients outside of Bethesda. And they were sending them home, and they were talking about what a fabulous care experience this was. Reduced hospital-acquired infections, better patient outcomes, more rapid recoveries. And I was like, that's where it's got to go. So this is probably going back 17, 18 years. So COVID literally took our business model that I've been talking about for 3.5 years and accelerated it forward by about 5 to 7 years because people are realizing I should only be going to the hospital if I'm really, really sick. I could get almost every surgery I need done in an outpatient environment, go straight to PACU at home, care at home, telehealth visits, unless somebody has to really see me. And now, again, the resolution's getting better. The technology's there to do monitoring. So I think it's all going to go home-based. And unless you have a cardiac event or a major neuro issue where you're going to be in the big house, and then you need to be in the big acute care facility.
Right. It's fascinating to think about how this is all happening very fast. I always felt like we'd always be hospital based, and just listening to you guys, both of you, there's plenty of benefits to agencies to start thinking about becoming more digital, more personalized with their delivery on all ends, retention, client outcomes, cost savings. I could keep going, but
yep.
I'd like to think about the consequences. So this is the direction everybody's going, right? What happens if I'm an agency owner and I just don't really want to change anything?
I don't think you're going to last that much longer out there. I mean, if you're a small agency and you're still on paper or not looking, in the next 1 to 2 years to adopt technology that, meets these needs we've talked about, it's slowly going to dwindle. The other thing too, John, that I was kind of thinking of, the patient-centered medical home. So, I mean, in clinically integrated health systems, that's such a huge thing. And home health is generally the wild card in all of that. It's like they can manage that in a rehab facility, but as soon as they step down to home health, and it's like, that's the companies. And, we can get down to a nurse in those when we would look at data. I used to do this in a big health system.
Yeah.
And it's like, when this particular group is the one that provides the home care, there's a twofold risk of readmission back to the hospital. So it's like, we don't know what they're doing differently than other home health agencies are, but we can tell when we send them out there, that's a piece of it. And so the technology that exists in implementing these EMRs helps to start to integrate that stuff too. So medical devices in the home, it's like that can plug into an EMR, that can feed somewhere else for machine learning, everything else to track clinical outcomes. That's the way these big health systems are going too. So, I mean, if you're still on paper, there's no way to participate in that marketplace for clinical integration that's happening across the country right now. So, I mean, that's aside from just patient and employee satisfaction, you're probably going to lose people that want to do business with you down the road too, if you're not able to aggregate and work on that data in your system.
Andrew, that's spot on. And it's interesting. I've analyzed a lot the bias. You get a lot of bias when you have the home health care company that's owned and managed and staffed by the acute care system in that local market. Because part of what happens is they were nurses in the acute care hospital, right? And their belief is those darn discharge planners, they're kicking them out too early. This patient should be back in the hospital. They should be at home. So they want to do a readmit. It's just the bias of kind of where they come from. And one of the things that is interesting, back to your original question, Aaron, if they get beyond 30 to 50 patients, the entropy and the ability to communicate and do the things that Andrew was talking about, it's going to overwhelm them. They cannot do it without making these investments in systems and technology that allow them to do this. And they're just going to be very, very limited in what they can do in their market, and they'll get passed by because they won't be able to report it or go. But I think in particular, having that ability to sort of track patients longitudinally and to come up with risk factors and criteria that determine, am I at risk for rehospitalization or not? The other favorite one, and Andrew, I know you know this with your background. I went to the hospital. I stopped taking everything. I got sent home, but I have a red pill instead of a white pill. The red pill is not something I take, so I don't take my diuretic. And I go home and I party like a rock star because I'm home. I watch the college football game. My team wins. I had a lot of Tostitos, Doritos, Cheesy Puffs, and margaritas, and I'm suddenly getting readmitted because I didn't take my diuretic. I don't know what that red pill does. They don't remember. That's hard. And I think telehealth, and thank goodness for the waivers that have come up. And Aaron, that's something I know we've talked about before. Yeah. Telehealth is here to stay. It is so much more powerful. It's more meaningful. Anyone who's lived through the experience of getting mom or dad ready to go to the physician for that face-to-face, it's a day off of PTO. It's like getting ready for Easter Sunday service. I mean, they show up and the doc asks, so how are you doing? Oh, I'm great. And you're like, no, you're not, Mom. You're not sleeping. They don't tell. It's the white coat syndrome.
Yep.
So this is something that's going to be interesting to see how this personalized experience and if you're going to be in home healthcare, you've got to treat yourself like you're literally an acute care system without walls, and you're a large physician practice without walls. You got to make these investments, and it's going to continue to be scale, continue to be organizations that can monitor, report, and take over. And it's something that we've talked before previously, Aaron and Andrew. I know you're seeing this. The models are not going to episodic care anymore. It's going to longitudinal care across a continuum of care, because we don't age episodically. We age kind of across a continuum. That's what's different. Acute care is, I broke something. I got an appendicitis. I had a gallbladder issue. I had a labor and delivery. You go, you get fixed, we send you home.
Yep.
Not you age in place.
Yep. HMO model on steroids now. They finally have the data to try and make sure that people are doing the right things and not just trying to reduce spend.
Correct. ACOs or HMOs at a community geographic level. Yeah.
And that's excellent advice and a stern warning for those people who are still on paper. And I know that if there's 30% at least of agencies across the U.S. that are still operating on paper, this is where their ears need to be perking up, right? And, I want to talk a little bit further here. I did a little research and learned that the very first home visiting programs in the US started in like the 1880s. That's a long time. So home health, home care, this is not a new invention. But if you are paying attention in the conversations that we're having, it feels like we're talking about something brand new about shifting more of the care in the home. Because our care delivery model, of course, is still very hospital-based. We've talked a little bit about this already. And I think in part because to date, all of the technology that was needed to diagnose and treat was housed in the hospital. So in order for us to be successful delivering this person-centered care in the home, especially, when we're dealing with the chronically ill and the frequent flyers, like we have to start thinking about leveraging these new and emerging technologies. And I know, John, you've mentioned some of this. Andrew, you've mentioned some of this. So I'm curious, what role do you believe technology systems can play in both during and after we completely transition to this more personalized care model in the home?
Andrew, why don't you go first? Because I'd be curious, because you do so much technology implementation. I really want to hear that answer, because that's where the failure point usually is in implementing the technology. And then I'll come back and talk a little bit about avoiding fatal mistakes that I've made in the course of my career to give you some color to what you're about to probably tell us.
It's going to be great.
So, right now, we've talked a lot about moving from paper, making sure you have an electronic health record in place. So that's step one. But as far as I know out in the market, there's no electronic health record that I can go and link my Apple Watch to or my Fitbit to track my sleep, my heart rate, other things that are critical vital signs that are coming in, or even just linked medical devices in the home that have a really easy integration for caregivers where it's like, hey, go put on your blood pressure cuff, 5 times a day and we're going to check it. And if we have an issue that comes back from that, or vitals are out of parameter for some reason, bam, I'm going to send that message out to a case manager. I'm going to send it to the physician to let them know. We have this technology where we know who the person is, all this information about them, what's on their plan of care, but that's the missing link right now. And that's the call for our technology providers to know that that's ahead. And from a vendor perspective, I think that's going to be a differentiator in the next 5 years for whoever can. We go onto our little Amazon, account and we link in all of this stuff to our electronic health record portal. That's what we need. And from there, we can start to get all of this crazy amount of data that comes in. So it's like, if my heart rate starts going up, I have these diagnosis codes. Now we've got that fundamental data to start looking at that and predict readmission risk and other things from it. Right now, we're just blind. We're relying on the caregivers in the home. And I'm sure if you went and asked the nurses out there, they would love the assist of having that constant flow of data coming in to provide better care for their patients.
One of the things that I think, Andrew, we tend to rely upon too much in the home health environment is too much data on the medical aspects and the physiological aspects of what we're measuring for care. And so a lot of what I think is going to happen, Aaron, when I look at this, the social determinants of health and ability to integrate an entire set of feedback loops that start to paint a picture of the patient for changes. It's the change that you're looking for. Where are they at? I refer to aging as like the old plate spinners that we used to see on the old Johnny Carson show years ago, right? And if you look at it, sometimes the plate looks perfectly level, but then it starts wobbling. And that's how older folks get. Then they level out, then they're good, then they wobble again. But I look at things and that we want to start tracking, are they having more sense of a sense of belonging and purpose, or is that disappearing? Do they have a sense of hope or not? Are they eating? Are they worried about food, food scarcity? Do they feel alone? Do they feel, just things that are kind of pre-indicators, kind of where things are, but also doing things that are not part of our current reimbursement models because they have nothing to do with an episode of care. Like you talked about that, Aaron, we've been around for 52 years. And I tell people all the time, healthcare used to be all at home. Then Sister Irene Krauss and her friends dressed up like Sally Battrill at Daughters of Charity, built these hospitals with x-ray machines and everything else. We started leaving the farms and going like ants to go get stuff done and leave. And even now, we still bill in an episode of care. That's not how we age. We're going to age across a continuum that requires independent living support skills at the front end. And we may have to go in and actually put in some ramps, put in a second handrail, go in and take the area rugs and roll them up so that they don't trip, right? Get rid of the antler lamp because it makes a really lousy grab hold, and put it on the other side so they can't stab themselves in the chest like Steve Irwin, right? And put the furniture up so that mom or dad can cruise like a 10 or 11-month-old and cruise to the bathroom because they're not going to use the walker sitting right in front of them. You know, this is stuff that I talk to them all the time about. Go change the furnace filters. People are like, what? I go, change their furnace filters. Have you looked at some of the furnace filters in an old person's home? They forget to change them. They get chronic lung infections because the filters have 3/8 of an inch of dust and mites in them. And people are like, well, you can't get this paid for by Medicare. Exactly. This is where the model of payers, I think, Andrew, are going to lead this with us. Mm-hmm. We're going to take over their patient care. We're going to avoid these hospitalizations driven by a fall because we started reducing the risk. We tore out the fiberglass tub. We put in a zero barrier thing with 2 seats in it so that the patient can safely be there and I can safely get in my shorts and give a shower to them or the other care provider. The model's going to shift. Aging in place is different, Aaron, than an episodic care model. But I think in particular, the way people need to view their technology decisions is not about what we're doing today, but where we see it going 3 and 5 years out. Because if they buy something for today, they've only solved today's problem and the market's already moved. And it's sad to see that, but they don't realize you're locked into something. And they also don't do it. I'd be curious, Andrew, for you to comment on this. The lack of re-engineering of inefficient workflows at the time they deploy technology. That to me, and I'd love to hear you comment on that as you've gone through installs, because that's when I've looked at things that failed in my career, it's because we didn't do the re-engineering work at the same time you put the technology in.
Yep. No, 100%. I mean, a lot of the engagements that I'm on, that's a massive part of the project is one, just getting set up for the culture change that it's like, hey, like you've done this for 20 years at your home health agency. It's not going to be the same when we go into an electronic health record. The way you deliver care in the field is going to be a little bit different. There's going to be steps for it. I've been fortunate that in the engagements I've been on so far, they've acknowledged that. And they're like, you know what, like this is an opportunity for us to kind of open the book, clean slate. And it's like, let's really look at what we're doing. And then within implementing a new technology, there's generally a lot of best practices in there. It's like their implementation and their notes and other things have evolved from other agencies' input. So it's like, you built this one visit note, 10 years ago, and you've never changed it. There's a visit note we can adopt from this system that's had agency input for the last, 15 years they've been a vendor. So those are huge things for them to really like open that up and see. And I've seen failed implementations, exactly to your point, where they're like, oh, well, we did billing differently and this can't support how we do billing. And it's like, there's 10,000 customers on this software that are doing billing just fine. Like, what is so unique about you that you can't use that? And it's like, oh, well, we don't like clicking this button and then pulling this spreadsheet out. That's different than what we used to do. So that's a huge thing of just like the change management and making sure the leadership team gets the teams ready for that. Some are good with it and some are, I've done this the same way. I don't want to change my process.
Yeah.
That's one of the major hurdles that I come across in my day-to-day as well. People like change. They just don't like that transition period.
Yep.
John, you were going to say something.
Well, Andrew made another comment. It was really interesting talking about the multimodalities of different kinds of technology tools and things that exist in the home. I mean, I remember when Best Buy made their big splash, right, about, we're going to have this technology-enabled senior living at home. So I've been to every Best Buy I can find in the country when I travel. You can't go see it yet. Oh, yeah. We were supposed to have that. Yeah. So it doesn't exist. And what's sad is you've got a lot of these devices and things that can give you stuff. Like I test the KardioMobile stuff. I try things out just to see, is this stuff that our patients could actually use? And a lot of it is, yes, they're passively being monitored, like Andrew said, but it's not linking up and attaching to our electronic health systems in a way that allows for an intelligent alert to go off. But you have to be careful because the last thing you want is an alert that you ignore. that's a bad day.
Yep.
That's where
It's
the
got to be
lawyers.
the right kind of alert.
That's
Absolutely.
where the lawyers get called right away and say, "How big a check are you writing?" Right,
Yeah.
and that's not what you want to have. But I think there's a huge opportunity there to provide a lot of integration with this technology in a way that's different and takes into account. It's there, but it's not really in their face, right? No one wants to wear a life alert. It's a badge of dishonor. However, what you can do is the technology exists. I was at Hewlett Packard at their worldwide conference where you have machine robotics and control arms. They can image a room and they could look at the room, a living room, bedroom, kitchen setting, and they could tell if a patient, because I had the guy that developed it come over and I said, "Can you tell me if someone was laying on a floor here for more than like 60 seconds or 2 minutes and have an alert go off?" He goes, "Oh yeah." And I said, the phone would then ring to our call center. And I go, "Mr. French, this is John at Intrepid. Why are you on the floor?"
I'm napping.
Yeah. Oh, Fluffy knocked the food over. Fluffy's eating your ice cream, right? This technology does exist. We haven't just integrated it in a way that seamlessly fits in within the patient's environments. And I think patients and families, Aaron, you talked about patient as payer, the Australia model. Look, the largest single growing payer in the United States is the patient as self-pay. That's going to continue. And, I think we all need to plan for we're all ideally, maybe we're 80% Medicare now. If you're running home health care, that's great. You better be planning on being 20 and 30% Medicare in 5 years, because you've got to come up with a different way to provide value and take care of these patients, because, you and Andrew are going to be paying for the patient care for your families and for your family members, or they're coming out of their spend down money from their retirement. It's going to have to be invested well.
Yep. That's an excellent point. So it's definitely an interesting time where we're valuing the use of technology and we're also valuing the whole person in terms of care. We're now recognizing that this will speak to you, Andrew, behavioral health, like my mental status, like my mood and my environment, all of that plays a critical role in the outcomes of the client. Mm-hmm. And it's just super cool time to be in the industry where we have all these technologies that if you apply artificial intelligence and the algorithms, like you can be really predictive. And that's where I'm seeing lots of interest on my, in what I do day to day is how can we be predictive, churn, outcomes, all these different things that we can solve with technology. And I'm going to shift gears just a little bit here and talk about something adjacent. Working for a technology company myself, I've seen a lot of disruption that these EVV mandates have had across the nation. But disruption isn't always a bad thing, right? I've also seen some of these agencies really embrace EVV and use that to drive efficiency and improve client care because, they're there on time. They did all their tasks. You have to do that in order to bill, right? So I think that in some ways it's a painful transition, but it might be a good transition. But I'd like your opinion. How has EVV impacted caregivers? How has it impacted agencies, like in the immediate? And what do you think is going to happen long term?
So I'll jump in if you're okay, John, on that one.
No, I'd love to hear your experience. I have an experience of one. You have an experience of many. So yeah.
Well, and you may by state, depending on what payer sources you have. So, I work with agencies across the country. And so, we have a federal mandate for it, 1/1/23 for nursing in the home, but states could adopt to do it sooner, and many have. So I've been kind of, with the agencies on the scramble of, here's kind of, in the short term, not a lot of communication from the states and kind of very ambiguous requirements that they need to meet with that. And ideally, we, to our point of making the technology easy for the caregiver, we don't want to have a second phone or app that they need to do something with. We want EVV to be integrated with the current systems that they're using. So it's like I clock in for the visit. That's my time for payroll. That's my time for billing. And that's my time for EVV. So that's been a big project to make sure that that's integrated properly and working for caregivers. The agencies I've worked with fortunately took this on as like project early on. So it's like we really looked at the caregiver experience. Basically, we're like, we want nothing else to change for them except that like you now, when you get to the home, need to do this. If you don't, the back office is going to call you when you haven't checked in for an hour and be like, hey, why aren't you checked in? Or you're there. Oh, yeah, I forgot. Okay. And we'll track that. And eventually they get in the habit of doing it. So everyone's pretty much made that transition. Longer term, once you're through the pain for that piece of it, it's been interesting to see the data for it. So, caregivers love them. Like they are the ones that, heart and soul of a home health agency, but there are some bad apples out there. And it's like, we didn't really expect that we would see that, but we're like, hey, we can see where you're clocking in for your visits. And it's like, you're in another state. Call the home, the nurse isn't there. And it's like, oh my gosh, like we just got fraud, waste, and abuse through the EVB system, which is what it was implemented for. So that's been a huge thing. Not a lot of people, but it's like, it was surprising. We didn't expect there to be any. And there's been a couple that I've seen across the agencies I've worked with. The other side of it too, just, are they there? You have a patient with dementia. They can't remember when their caregiver calls up. They call to complain like, oh, Nurse Betty was a half hour late today. And, I'm really upset about that. And it's like, no, Margaret, we're looking at our system here and we can see that they were actually at your house 3 minutes early. Oh, they were? Like, you can see that? And it's like, it gives you an additional data point where it's like, it used to be self-reported times coming in. And it's like, we didn't really know as an agency if that nurse was there or not and who was really telling the truth in the matter. Obviously, we want to, lean toward the nurse side if there's a behavioral issue with the patient, but it really gives that transparency and visibility. The next thing that scares me, though, with EVV is, we've implemented this early before the federal mandate and, states have continued to push out, their reimbursement requirements and making sure that claims are matching. That's been very scary to audit the data for. So it's like in some states, we can see if there's an EVV match to a claim that we submit, basically the precursor for eventually this would be denied and we'd have a secondary process for it. Those percentages are not great yet. And it's like, I think, whenever they finally hit that, that's going to be another staffing impact for the billing and revenue cycle teams to work through those denials where EVV data didn't come over. So I'm hoping states are mindful and, they're looking at that to not put more burden on the agencies. But, I think we've got EVV and the technology down for it. That's the next piece of it is how does this impact the revenue for the agency? And, how do we get ahead of that before there ends up being a cash flow issue down the road?
And it's interesting when I look at it, Aaron, I think to piggyback on what Andrew's saying, I just see it as a normal part of the course of our business. And it's a great tool to ensure that we actually did what we said we were doing. Right. And this shouldn't bother you. It's in the background. It's occurring. Did your geolocation map what you said you are? No, Starbucks is not where you're supposed to be right now. But I think, Andrew, to your point, the pressure on us that we're going to feel is as they start to say, well, okay, so we're supposed to have contemporaneous written documentation, everything done in the home. And a lot of our care providers are like, well, I can't finish it all there. I can't finish it all in the driveway. And even though we're pushing, saying you really need to, because if you wait till tomorrow and you're trying to finish off all that documentation, you're kind of guessing. It's like taking your expense report and trying to fill it out at the end of the month when the American Express statement comes in. Okay, I know I had lunch. I know I did this. You're guessing, right? So I think the risk factor is as the states use it, do they start ratcheting down reimbursement mechanisms to say it all had to be completed right then and there, or anything that was done? Now, certainly you can have modifiers and things for clarification, but I think, Andrew, to your point, they may try to use it as a basis for denial of reimbursement if it wasn't all completed at the exact time and physical location of the visit. That I think is something we're going to have to get some flexibility on, because there are certain things that would be follow-ups that may be added to the document, but there may be what we call core elements, right? Vitals, kind of medication, review and medication reconciliation. That kind of stuff had better be documented there and not necessarily later. But I think that's the risk point. Otherwise, it's just part of business. PDGM, oh my God, the world's going to end. No, it didn't. It didn't end. And, EVV is not going to cause the end of the world or cause people to leave the profession or whatever else. Those 1 or 2 percenters that are trying to game certain things or think they can get away with it, again, that's another reason to have electronic systems in the first place. You don't have somebody saying something. And I think, Andrew, your side of it helps eliminate, service recovery issues that are phantom issues, because sometimes they don't remember that they had the visit. My father-in-law we could have had the home healthcare person come by and leave in 2 minutes and say, hey, did they come by? And he'd say, no, I haven't seen them. And literally I could see the car coming down the road from the other end of the farm. And it's like, Tom, they were just there. But, he had some of those issues. So I think it's an important factor, but I think it's going to be one of those things, Aaron, that's it's taken for granted. So long as it occurs in the background, to Andrew's point, and doesn't put a huge burden on the care team member, it's okay. Because that's one of the things when I used to sell electronic health records and develop them, I was always looking at not just a return on investment, but what's the return on clinicians' time? I used to call about ROT. And they'd be like, what do you mean? No one else talks about that. I go, I know, because they're trying to sell you something that isn't going to give you a return on time. I'm going to show you why this is going to be better, faster, easier. And yes, certain things are going to take more time, but here's where it'll save you time on the back end. And they go, now I'm interested in what you're talking about. So that's, I think, the developers of the systems are the ones that are going to have to continue to provide ways to help provide prompted checklists that are more accurate, or as I'm checking things in my evaluation of the patient, that it does a good job auto-generating sections of a note that I can edit and or maybe clarify. That starts to speed up my care day. That's what I care about as a clinician. If you're asking me to take the time to fill this out.
And that's going to keep you happy. You guys are just highlighting the importance of having the right technology partner to help you run your business, which is a nice little segue to one more question. We have time for one more question before we wrap up. I imagine that a lot of our listeners don't have a ton of experience evaluating, selecting, and implementing technology. And I bet many of them, especially those that are still on paper, are thinking after listening to you guys talk that it might be time for them to start thinking about implementing some technology tools. What are one or two things, little bits of advice that you can give to those who are thinking in that direction right now?
I'd love to go first because we went from paper to electronic about 5-6 years ago. So I'm speaking to the people that went from paper to electronic, right? But even if you're on another system right now and you're considering upgrading or changing, number one, make sure you look at where you want to be 3 to 5 years from now. Do not make your decisions based upon where you are today and where that technology that you're evaluating is today. Make sure you ask them to see their roadmap, and you want to see their technology roadmap coming out. That's an incredibly important decision. And then the second thing I would share, and that I'm just fanatical about, is do your business process reengineering work to change the stuff that's garbage and horrible and don't carry forward bad habits. Do it now, or you're going to have to do it later when you have a failed implementation that really wasn't a failed implementation. Your people successfully resisted the change and were able to fight you in a way to stay where they were.
Andrew's going to have fun with this.
Do not let them do that. Because that's just, and choose carefully. The third thing would be choose carefully where you pilot, because we've piloted things so many times that failed. I don't even want to go through the story. And I'd go, where did you pilot this? And they go, well, And I see some locations. I go, not the right thing, right? I just sit there and go, who made that decision? Because anyway, but those are my top 3 things. And Andrew, I'm sure you're going to have a much more elegant and just, storied answer that I'll look forward to hearing. So this would be great.
Yeah, I mean, the biggest thing, when I first come in on these engagements, sometimes, previous implementations failed bad technology. Sometimes they just completely picked the wrong thing that didn't make sense for them. So first part is just coming in and it's like, let's make a shopping list. Like, what is it specifically that we need to do, especially if you provide Medicaid services, because Florida is completely different than Texas. It's different than Illinois. And it's like every one of them has a nuance that you need something to be done in the EMR to support those workflows. So getting those on paper so you remember what those are. Because we've all been through demos before, and it's like you see 3 different products and it just becomes a blur in your head. You can't remember who does what. That also gets buy-in from those different teams. So it's like if the billing team needs something special, now we're asking about that and making sure that the system can do the things that it needs to do. Same on the clinical front. It gives you a roadmap too for when you start looking at products. So I don't know how many EHRs there are out there for, home healthcare at this point. If there's new stuff popping up all the time, Erin probably has, a number from her side, but there's a lot. And, some are Medicare specific, some are Medicaid specific, some can do both things, some are pediatric, some are adult. So that shopping list helps make sure that you're in the right spot. So it's like if you're on a sales call and it's like, I'm at a grocery store to buy things, but there's sporting goods around me. And it's like, just eliminate them off the list. There's no point in spending, another 8 hours on demos with them. The salespeople will continue to give you demo after demo, but it's not the right product. So you get down to the right ones, start to evaluate them and, go down that punch list. To your point, John, on, the teams and kind of, who does what in it. And it's like, no EMR does 100% of things. And it's like every engagement I'm on, and it's like, we're going to go down this list and we're going to have probably 90% of these things that a vendor meets. And it's like, we need to then evaluate between the vendors, who's going to take the hit on the 10%. That finance has to pull some weird spreadsheet and run some pivot tables on it to make it work. But the other one had a fancy BI tool. But the other one's better clinically. And it's like, where are our priorities in the selection? And, is that something that you can live with? It takes you 20 minutes a month, but we have a much better clinical product. So those evaluations are huge in making sure that you can make those trade-offs. Next thing is read the contract. I have so many agencies sometimes that I'll come in with, and they've never read their contract with their technology providers. And there's, tons of little just loopholes and things. And to John's point, this is a 5-year engagement. This may be the last EMR you ever select. So it's like, you want to make sure that you've got a contract in place that makes sense for both you and the vendor moving forward to continue to build and grow that partnership with each other. And then lastly, just a key point is on the staffing side. And so it's like, if you don't have someone, internally that is, good at project management and helping to guide these things, you either need to hire someone or bring in a third party to support with it. Because a lot of these go sideways where it's like, hey, John, you're now also in charge of the EMR selection and coordinating vendor demos and the implementation. And you're like, okay, that sounds great, but I'm already working 40 hours a week. Where am I going to find this other 30 hours a week that I need to successfully manage this project? And it seems like an investment up front. It is. But also, once you implement this technology, someone needs to manage that moving forward. There's releases, there's ongoing optimization that needs to happen, there's education, there's issues that come up that need to be worked through. So don't cut yourself short and implement a great technology product, but then not have someone internally to support it. So in all cases, there's going to be additional labor required for that. You're going to hit savings on the clinical side, on the compliance side, on the billing side. So the cash is there to make up for it, but it's like, don't discount the fact that you're going to need someone to support the product moving forward.
Yeah, and
very,
Andrew,
very good advice.
Sorry, and Erin, Andrew just shared something I just want to piggyback on. He
Sure.
I think his point about don't underestimate the value of an independent party that helps kind of becomes part of your project management PMO office and the evaluation team, they'll help eliminate what I call the emotional, political, entrenched position biases, because they'll be like, well, we just don't like that. Well, why? Well, because the font wasn't the right font. Okay, that's not a good reason. In other words, that value that Andrew can bring, or organizations like Andrew's can bring to that process for organizations, is critical, because it removes your institutional bias for no change that occurs and levels the playing field for any of the objections to be factually based, not just emotionally, or I don't know, they give me better tickets, they take me to better events, they buy me better dinners, et cetera. Right.
Yeah. No, that's 100% right. And it's like, I've been the wedge in, those teams sometimes before, where it's like, I don't understand what the actual issue is. And it's like, let's look at a specific example, document it. And it's like, oh, well, it's not really an issue. And it's like, I just don't like the way they do it in this location. And it's like, I don't think that's right. Well, why specifically? I don't know. I just don't like it. It's like, okay, well, we're moving on then, because this is a non-issue. But it's true. And it's like, and I have no political allegiance to anyone there, or a third party that comes in. And it's like, once the project's done, I stay around a little bit to help with things, but it's like, I'm out the door. So, that does help a ton too. And it gives me a unique position to kind of help keep the project moving along. But then, if you've got some teams that don't necessarily get along the best, it's a good mediator to help everyone have peace as these big projects move forward.
What, sales, ops, and clinical don't get along?
Shocker. That was excellent advice that you guys provided. And for the listener, it sounds like you need someone, an objective eyeball on the project to help you do a very thorough needs analysis and also analyze all of your processes, because those things are going to change. And then you need to be very selective and intentional about when and where you implement this via phased or pilot. I think that's kind of what I got in a nutshell. And I appreciate you sharing. And before we drop off, if somebody wants to get more information about Intrepid USA or Get It Analytics, how can they reach you guys?
www.intrepidusa.com. And we'd welcome an outreach, and certainly they can click on the links and reach out to us that way. We're happy to help. And if they're ever want any advice on different things we've experienced, we'll share the avoiding fatal mistakes discussion on a confidential basis with any of the senior leadership that want to call from there. But thank you, Aaron. And it's a pleasure to be on the podcast.
Pleasure to have you.
Absolutely. And Get It Analytics too for the website. And, if there's a link or something, we can publish that afterward. To John's point as well, I'm happy to have a quick call with anyone on the key pointers, or, if you're somewhere along in an evaluation process and just want to pulse check on things, always happy to do that.
Wonderful. Well, guys, it was excellent to talk to you today. I hope you have a great one.
It's our pleasure.
Thank you so much, Aaron. Appreciate it.
Home Health 360 is presented by AlayaCare. First off, I want to thank our amazing guests and listeners. To get more episodes, you can go to alayacare.com/Home Health 360. That's spelled Home Health 360, or search Home Health 360 on any of your favorite podcasting platforms. The easiest way to stay up to date on our new shows is to subscribe on Apple Podcasts, Spotify, or wherever you get your podcasts. We also have a newsletter you can sign up for on alayacare.com/Home Health 360 to get alerts for new shows and more valuable content from AlayaCare right into your inbox. Thanks for listening, and we'll see you next time.